Hello and good welcome to this afternoon's live webinar hosted by MSD and AstraZeneca. Today, myself and a colleague, Nicola Nomano, will be telling you about the outcomes of the HRD EQA scheme that we ran this last year. Plus, we'll also be giving you an update through Nicola on the status of HRD testing and then the sort of state of the art, if you like. This is a live webinar. Next slide, please. So to introduce ourselves, my name is Dr. Simon Patton. I'm the Chief Executive of EMQN, and I'm joined today by Dr. Nicola Nomano, who's the Director of the Centre for Advanced Medical Diagnostics and Oncology based in Rome at the Polyclinico University in Rome. Next slide, please. This is the agenda for today. So we're going to give you, through Nicola, an overview of the latest developments within HRD testing to sort of kick us off. And then I'm going to present the outcomes of the EQA scheme that we ran in 2025 for HRD testing. At the end, there is a live Q&A session, so we encourage you to submit your questions to that. And hopefully that should bring us bang on time for our hour and a half of presentation. Next slide, please. A few housekeeping notes before we get started. So we've automatically muted your microphones to avoid any background noise. We are recording this webinar, so if your colleagues are unable to attend and listen to it, then we will be sharing it through the EMQN YouTube channel and on our website. Probably sometime in the next 2 weeks. It usually takes a couple of weeks to go through compliance. But if you're signed up to this webinar or on the EMQN mailing list, then we will let you know in due course. Most importantly, the Q&A session is an important part of this webinar. We designed these EQA and the webinars that support them to be highly educational. So you have an opportunity here to ask questions to both myself and Nicola. Please use the Q&A session function on the bottom of your Zoom browser to submit your questions at any time. And we'll hold that Q&A session at the end of the webinar. Next slide, please. So your feedback also is important to us because we utilize that to help improve our webinars. So after this webinar, you'll receive an email from the organizing team, which will contain a link to a short survey. It should take you no more than 2 minutes to complete. I do ask that you try to contribute those 2 minutes to fill it in and let us know what you like, what you don't like, and what we could do differently. So thanks in advance for your contribution to that. We look forward to hearing your feedback. Next slide, please. So our disclaimers, this is a non-promotional webinar organised and funded directly by AstraZeneca and MSD. The views articulated are those of myself and Nicola and not necessarily those of AstraZeneca and MSD. And both myself and Nicola have received honoraria from AstraZeneca and MSD to support this webinar. Next slide, please. Okay, so without further ado, I'm going to introduce Nicola to give you an update on the sort of state of the art of HRD testing currently, building on the information we provided from last year. So Nicola, welcome, and over to you for your presentation.
Thanks, Simon, for this nice introduction. If I can have the control of the slides. Good. Okay, so what I'm going to do in my brief talk, I will try to give you some practical information and suggestion, in particular for those of you who want to implement HRD testing in their labs. But before doing this, I thought it was a very good idea to start with a brief recap of the role of the homologous recombination repair system and the mechanism leading to the efficiency of the system. Now, the homologous recombination repair is one of the one of several different pathways that are able to repair DNA break, but in particular, this is the major error-free DNA repair that is able to repair double-strand breaks and inter-strand cross-links. Now, a deficiency of this pathway has been observed in a number of different tumor types, ovarian cancer, but also breast, prostate, pancreatic cancers, just to make a short list. And what's very important for us in the clinic is that the presence of a deficiency of the homologous recombination is associated with the response of the biomarker of response to chemotherapy, platinum-based chemotherapy, and these target-based agents, the PARP inhibitors. Now, as shown in this slide, the homologous recombination pathway is quite complex. There are a number of different proteins involved in this pathway. BRCA1, BRCA2 play a central role, but there are also many other proteins, and therefore genes that code for this protein involved in this pathway. And as a consequence, there are a number of different mechanisms that might possibly cause HR deficiency. First of all, we have mutations, and these mutations can be either germline or somatic. Germline mutations can be inherited, and therefore they may cause also hereditary cancer syndromes, whereas the somatic mutations are acquired only by tumor cells. Now, these mutations might occur in BRCA1 or BRCA2, but we have to accept that these mutations might potentially also occur in other HRR genes. And then we have also mechanisms that are non-genetic, epigenetic silencing of HRR pathway genes, so it means mechanisms that will lead to lack of expression of the protein in absence of alteration of the genes that are involved. An example is the promoter methylation. So potentially, different mechanisms involved in different genes of the HR pathway might lead to HR deficiency. However, what we have learned, at least from the ovarian cancer, that the presence of variants in BRCA1, BRCA2 are almost always associated with an HRD phenotype. In contrast, mutation other HRR genes might not be associated with an HRD phenotype. It means that we found tumors that have a clear HRD phenotype, but without mutation in HRR genes, and there are tumors that have mutation in HR genes other than BRCA2 but do not show an HRD phenotype. Why does this happen? Most likely because some of these mutations might not lead to complete inactivation of the protein, or it's possible so that some protein can replace the activity of other. As a matter of fact, this is something we observed as well. As already said, there are cases of HR deficiency in the absence of mutation, and this again supports the hypothesis that also non-genetic events might lead to HR deficiency. Now, how frequent is HR deficiency in ovarian cancer? It's been estimated that about approximately 50% of high-grade serous ovarian cancer have a deficiency of the homologous recombination pathway, although mutations of BRCA1, BRCA2, including somatic and germline, usually occur in approximately 20% of the cases. So there is a large fraction of ovarian epithelial tumors that show an HRD phenotype in absence of a BRCA mutation. And why is it important to detect these tumors? Because we have now drugs, PARP inhibitors, that have been approved for use in patients with ovarian cancer that have an HRD positive disease. I don't like very much this definition of HRD positive, but still this is the most widely used now also by clinicians. So I think that to make the message clear also for the clinician, we need to use this terminology. Now, different assays and different approach to develop assays to detect HRD have been developed over the time, and the first attempt were based in trying to identify the causes of HRD. And basically, this approach was based on use of panels of genes covering the HRR genes, but this approach failed to demonstrate any correlation with the presence of HRD phenotype, and more important, with the response to platinum-based chemotherapy and with PARP inhibitors. And this is not surprising. Based on what I showed you, there are mutations in HR genes that might not be are not associated with an HRD phenotype, and there are tumors that do not carry mutation in any HR gene but still have an HRD phenotype. So I will say that this approach should not be used. It's very interesting the possibility to use a functional study to assess HR efficiency. Actually, the advantage of this approach will be to provide information on the status of the homologous recombination repair pathway at the time in which you perform the test. However, the attempts to standardize this assay have shown that this is quite difficult, so they are still far from reintroduction in the clinic. And so what we usually use in our routine clinical diagnostics are tests that are assessing the consequences of the deficiency of the homologous recombination pathway. In particular, looking at genomic scars and mutation signature that are a consequence of the high level of genomic instability that have deficiencies of this pathway. Now, sorry. Now, this slide is only a partial list of the several different commercial tests that are available for HRD measurement. And as shown here, different technologies, different algorithms are used by these assays. I will not have the time to get into detail of each of them, but I try to give you some insight. Now, if we look at the target NGS panel, which are the most widely methods used for HRD measurement, we can subclassify this list of panels in two groups. The first group are the assays that were developed specifically for HRD measurement. The prototype, of course, is the myriad choice assay, but you see there are other tests coming from other companies, FMI, MODX, QIAGEN, SOPHIA GENETICS, but this is, again, only a partial list. Now, all these panels will provide information on the tissue status of BRCA1, BRCA2 genes. Some of these panels will also provide information on other genes of the HRR pathway, not all of the panels, but some will give you this information. All these pathways also include an HRD marker, but this marker is different from pathway to the other. In the myriad by choice, the genomic stability score is based on loss of heterozygosis, telomerical imbalance, and large-scale transition. In FMI, only loss of heterozygosis, and then we have the GSS, MODX, the HRD score on QIAGEN, the GE score of SOPHIA GENETICS, all based on different biomarkers. The algorithm to call HRD status, however, is similar for this pathway. Now, if a tumor carry a tissue BRCA1 or BRCA2 mutation, the tumor will be immediately classified as HRD positive. In absence of mutation in BRCA1, BRCA2, then you start to look at the HRD marker. And what is important to highlight, however, is that the cutoff for this HRD marker is different from an assay to the other. For myriad, the genomic stability score, the cutoff is 42. If you go to FMI, it's 16. MODX and QIAGEN have a cutoff of 50. And finally, SOPHIA GENETICS is 0. And similar heterogeneity is also found in these other assays. These are assays that were really developed for comprehensive genomic profiling, are used by some academic institutions for comprehensive genomic profiling, but can provide also information on HRD status. Again, this assay will provide information on the mutational status of BRCA at the tissue level, but most of the HR genes, if not all HR genes, are also covered by these large panels. The HRD marker are different in the different assay, LOH for the MI, FMI. For the Illumina, we have the same genomic stability score of myriad because of an agreement is made by between Illumina and myriad. And for Thermo Fisher, we have this genomic stability matrix. And again, the argument is the same. If there is a tissue BRCA1 or BRCA2 mutation, then the tumor is immediately classified as HRD positive. In absence of the tissue BRCA mutation, then you look at the HRD marker. That would be LOH with a cutoff of 16 for FMI. For Illumina, it's GIST with a cutoff of 42. And for Thermo Fisher, the cutoff most likely will be 16 or 19, depending on the platform that is used. Now, it's clear that this heterogeneity might create a lot of confusion also in the oncologist or the gynecologist when reading the report. So my first suggestion is really to provide a clear interpretation of the HRD testing results. I would prefer HRD signature detected or not detected, or HRD positive negative. So please don't give only the score, the number, because most oncologists are not confident with the difference in the cutoff between the different types of assay, and so Also, if you provide only the score as a result, this might lead also to misleading interpretation of the result. Now, how to choose now the best HRD assay for our clinical practice? Now, this is very difficult. This is a study in which a number of experts try to make a list of the parameters should be taken into account for HRD assay validity. Almost all agreed that an HRD assay should cover tissue brachiotatus and the genomic stability using an HRD marker. And as shown here, what is suggested that this assay should have a very good analytical and clinical validation prior to their use in routine clinical practice, and also some metrics in terms of agreement, negative percent agreement, over percent agreement are shown here. And just to show you, I'm sure it's not easy to read this very busy slide, but you can go to the publication and you will find a list of different academic and commercial assays for HRD testing, which have a very good data for analytical validation and clinical validation, and in particular for the clinical validation. These data were obtained by using samples deriving from clinical trials, the PALA-1, the PRIMA, the Ariel, or the Athena trial, and this is very important, I would say, to have such type of correlation. So my suggestion here is that if you want to start with, if you want to implement a genomic stability test in your center, please use a test for which a robust analytical and clinical validation is available, and you can ask also to the commercial provider, if you go for a commercial test, to show you this data before choosing a test. Now, there are different studies that look at the agreement between what we use as a reference test, the median, my choice, and a number of different panels. I'm showing you the results of this study that was run in my previous lab in Naples, in which we looked at the concordance between TSO 500, OCA Plus, and SOFIA versus the median reference tests. And what we found is an agreement that ranged between 95.3% for median, 88.2% for OCA Plus, and 91.9% for the SOFIA genetics assay. I've said, however, that we found very good correlation with outcome with these three different tests. Now, when we looked more deeply into the discordant data between these different assays, what we realized that in many, not all, but I would say most of the cases in which there is a discordant results, the value of the score of the HRD marker is close to the cutoff of the different assays. So this led us to hypothesize that at least in part of this discordance that we found between the different assays may be due to tumor heterogeneity. And indeed, in this respect, there are some studies that have demonstrated that there is a quite high level of heterogeneity for clinically relevant biomarkers of ovarian cancer, including HRD score. Now, some colleagues, based on this data, have suggested that we should really test for HRD in three different areas of the tumor, but we know that this is not feasible for the practical consideration, but also for the cost of this assay. However, I would recommend that if you find an HRD test with a result with a score that is close to the cutoff, well, this data should be really discussed in the multidisciplinary team, taking into consideration also the clinical data, in particular the response to platinum-based chemotherapy. If you have a tumor with an HRD score that is close to cutoff, but the patient had a very good response to platinum-based chemotherapy, I will rather consider that tumor as an HR deficient rather than HR proficient. And so this should be really taken into consideration, integrated the clinical data with the data from the test. Will allow to have a better management of the specific case of the specific patient. Now, when we looked at the concordance between the three different assays, TSO 500, OCA Plus, and SOFIA versus median, we are quite surprised also in finding that there was no perfect agreement also for the BRCA mutation detection. You see that the agreement rate was 97.7% for TS500, 95.6% for Roca Plus, and 94.2% for the Sophia Genetics. Still, I don't know, we are surprised to find that there are some cases that were detected by some assay but not by the other. But when we looked at the sequencing data of the different parts, what we found that for most, if not all, of these cases, the BRCA mutation were really identified by all the panels. What really was different was the classification of these variants. For example, some variants classified by Myriad as VUS, then variant or non-significance were classified as pathogenic by other panels, and the other way around. I mean, variants considered as pathogenic or likely pathogenic by me were considered as non-classified or variant non-significant for other partners. So now it's very difficult, to go through this data. I'll say that we ran this study 3 years ago, and we know now that the classification of BRCA variants of some of these panels significantly improved. Still, I mean, all these panels, these pipelines will use different database. So here my suggestion is that if you have a case with very high genomic stability score, you might want to look at your sequencing data just to make sure that there are not BRCA mutations being filtered out, and indeed if there are BRCA mutations, you want to look at different database for their classification. And we know that usually the BRCA mutant tumors are those with the highest level of genomic stability score. I do understand that this exercise is quite time consuming, but you might want at least beginning go through this exercise just to make sure that your test is correctly classifying all the BRCA variants. Now, another important issue that comes from clinical trials is the success rate of HRD testing. In some clinical trials, I mean, there was about 15 to 20% failure rate of HRD testing. This is a study on pretty large number of cases that were tested with the Myriad My Choice, and here the success rate was pretty high, 90.3%. However, having available a so large number of cases, I mean, what these investigators did was to look at the characteristics that are associated with optimal chances of successful analysis. What they found is that a tumor cell content of at least 30% and the tumor area at least 0.5 square centimeter are usually associated with a better chance to have a successful HRD test. However, this other study that is in a limited number of cases, but still cases that were tested with the medium match choice, reported a much higher failure rate. The overall success rate was only 76.8%, and for some patients, repeated testing was necessary. And what these investigators found is that the tissue collection point and the needle gauge used for the tissue collection to radiology really influenced the success rate. In particular, in the upper right panel, you will see how the primary surgery did much better in terms of success of testing as compared with the diagnostic biopsy, and the worst results were obtained with interval debulking surgery. This is not surprising because if you had first chemotherapy, then this might lead to severe reduction of tumor fraction, but also phenomenal of necrosis and fibrosis that might influence the success of the testing. And with respect to the needle gauge, looks like that a 16 gauge is associated with much better success as compared with a smaller gauge when of course you are using a diagnostic biopsy for testing. And again here, my recommendation is that it's better for HRD testing to select a surgical specimen or even image guided biopsy of a treatment naive tumor. And of course, you need to have a sufficient number of tumor cells, an adequate tumor area, and as I've shown you, also use adequate needle gauge needles, to collect sufficient amount of material. The last point that I will touch is about the timing of HRD testing. There is always discussion whether we should test first patients for BRCA and then only test for HRD only the BRCA negative patients or go immediately for HRD testing. This group of experts put together by the ESMO and the European Society of Pathology did recommend that genomic stability tests should be performed at diagnosis, and this is because the availability of this information is very important because we provide predictive information that are not only predictive for the possible use of PARP inhibitors as maintenance therapy, but they are very important also because they are associated with response to platinum-based therapy. And so my final recommendation, actually my final slide, regard the use of HRD testing at the diagnosis of ovarian cancer. Now, this is my last slide, but it's not my last recommendation, because my strong recommendation is that if you want to implement HRD testing in your lab, you should participate to external quality assessment schemes for HRD. And Simon Patton will show you why this is important, how can this help you to improve the quality of testing. So Simon, the floor is please go ahead with your presentation.
Thank you, Nicola, and thank you for your comprehensive overview of HRD testing, state of the art, and recommendations for implementation if you are a laboratory. Next slide, please. Just to set some objectives of what I'm going to cover for you. So I'm going to give you an overview of the results from last year's pilot EQA scheme for HRD testing. Excuse me. I'm going to give you clear examples of the errors and pitfalls we've seen within that EQA, with some practical solutions, which when implemented can help prevent or hopefully rectify any common issues. Some guidance on reporting within different clinical contexts. And then obviously at the end, you've got an opportunity for some Q&As. Next slide, please. So Nicola's already gone over most of what's in this slide and actually in the next slide. But just to reiterate why the context behind this and the context behind PARP inhibitor therapy prescription and testing for HRD. So ovarian cancer is the 8th leading cause of cancer death in women, and up to 5% of all female deaths worldwide are caused by it. And essentially the main problem with it is usually diagnosed at an advanced stage. So the risk of relapse is high within 2 years of treatment on chemotherapy. First line therapy with PARP inhibitors for treatment of platinum-sensitive tumours has shown improved outcomes for ovarian cancer, progression-free survival and overall survival. And as Nicola showed, mutations in BRCA1 and BRCA2 represent one of the most sensitive predictors of response to PARP inhibition. And the benefit is also observed, however, for BRCA wild-type tumours with HRD, so homologous recombination deficiency, in those clinical trials. And again, Nicola's been over the details behind that. Next slide, please. I want to just emphasize the one point here that's really driving this discussion, and that's really the regulatory approval of PARP inhibitor therapies in combination with platinum-sensitive chemotherapy. Next slide, please. Now, from EQA, obviously that's the area of expertise within which EMQN has specialist interest in. The evidence we have, and actually evidence from quite a few other studies, or 5 studies listed on this presentation, is the implementation of any new diagnostic test is often accompanied by a high diagnostic error rate. And by an error rate, that's really an error that would cause significant patient harm. So poor quality testing by proxy, therefore, may result in patient harm. And one of the best ways to actually understand those error rates and to look at the landscape, if you like, of the testing process is to undertake EQA. And if you undertake EQA early within the testing process, you can help to drive harmonization and improve the quality of testing. Next slide, please. But EQA itself is only one part of the total quality improvement cycle. We have the educational component, best practice guidelines and training. And we're currently, Nicola's already showed the ESMO and European Society of Human Pathology, European Society of Pathology guidelines, on HRD testing. And we're currently working with various interest groups on writing best practice guidelines for the reporting of HRD testing. Keep a watching brief on whether hopefully those guidelines should be out next year. Next slide, please. Along with education as the internal quality control that the laboratory runs itself. So again, we've emphasised the importance of test validation, and with that comes a need for good reference materials, whether they be real clinical samples or artificial samples that replicate an HRD sample. All of that obviously is overseen by a robust and strong quality management system. Next slide, please. And finally, the need for EQA, the external independent oversight of the test process. And of course, this feeds into the regulatory cycle as well as the education component. But all of this, next slide, please. All of this drives improvement in the standards of testing, clinical testing. So EQA, as I said before, is an important part of that process. And implementation, certainly from the start of testing, is essential to ensure that the risks of patient harm from poor quality tests are minimised. Next slide, please. So within the context of this EQA, this is the second time we've run it. It's a pilot. The first EQA in 2024 was, if you like, a proof of principle. So this is a pilot EQA scheme, and our aims essentially were to assess the testing accuracy and clinical reporting of HRD in a clinical test setting. We were agnostic of the approach, so we encouraged laboratories that were using either commercial assays or in-house developed assays. And in keeping with all of our EQAs, the intention is to improve the clinical service using a combination of our assessment and expert commentary and feedback from our individuals who are supporting the EQA, through a combination of laboratory individual feedback to laboratories, so direct feedback to the laboratory, and a much more detailed and comprehensive EQA summary report that gives you a sort of benchmark of where you stand and all the common areas associated with this types of EQA, and more important, the recommendations and the education associated with how to improve your performance. So the format was we asked laboratories to correctly determine the genotype of the samples provided, to then to interpret those results in the context of the clinical referral we provided. We are also looking at the ability of the laboratories to use internationally accepted variant nomenclature, particularly in the context of BRCA1 and BRCA2 testing, and also to provide appropriate and accurate patient sample information and identifiers. Next slide, please. So the EQA itself was supported, as we already know, from MSD and AEZ, and we provided 3 clinical cases this year with their corresponding clinical information. And laboratories were asked to test and report those using their routine protocols. Again, no instructions about how to test it. Laboratories were free to choose the most appropriate assay they felt for the test process. To market and assure that we got an unbiased assessment of the laboratory performance, we had a team of 6 assessors, so 6 experts from 4 different countries, shown in the figure on the right-hand side. 3 from the UK, and then 1 each from Canada, Greece, and Italy. And we used a harmonised set of marking criteria for assessment to ensure consistency amongst all laboratories from our assessment process and reduce the risk of any bias associated with that. Next slide, please. So the principles, everybody received the same material, and this year we provided a mixture of real clinical samples and artificial reference materials. Results were returned to our EMQN for assessment. As per all EQA samples, we ask you, the laboratories, to treat them in the same way you would a patient sample. And the irony is obviously that in many cases people treat them more carefully than a patient sample. And then we score those results to determine the accuracy of the genotyping and the interpretation component of the report. So obviously the advantage of that is it's an external measure of the quality of your service, and we, through our individual feedback and through our summary report, we try to ensure that we're providing some robust education and training associated with how to do HRD testing. But of course, EQA does form a component of regulation, and performance monitoring, whilst applied to this scheme, because it was a pilot, there was no implications, if you like, for poor performance associated with laboratories making a mistake. Next slide, please. So now starting to look into a bit more of the detail behind the scheme itself. So obviously you can see this year it was the first sort of full pilot scheme. Last year was the implementation phase. About 50% of the laboratories that participated in the 2024 activity participated again in 2025. But the remaining nearly 70 plus laboratories were all new to the EQA scheme, which is great to see. Although it would be good to see more carryover of those labs that previously participated in the 2024 activity. And then looking at the breakdown of the geographic region of where the laboratories come from, about 70% of those laboratories come from Europe, with a smattering of other regional areas where the participation is just under 10%. But I think this probably also reflects the maturity of the HRD test process within the European setting. Next slide, please. So the 3 samples were provided with FFP samples. We have our own in-house cell lines in Manchester, and so we utilise those materials, that's the lymphoblast cell lines, to make the materials themselves. We selected specific variants with known results, and all of those samples were independently validated prior to sending to laboratories by 2 different laboratories using an NGS HRD assay. One laboratory used the Sophia HRD solution, and the other one used the Seq1 platform on the Illumina NGS platform. So again, it's routine practice to understand, to validate the gene types before sending them out. But obviously, with the laboratories participating, we've also got the retrospective analysis, so we can double check that the samples are performing appropriately as the laboratory results come in through the system as well. Next slide, please. So looking at the different cases in a bit more detail, so we'll go through cases 1 to 3. So in case 1, we had a scenario where we had a female patient who had been diagnosed with high-grade serous ovarian carcinoma at the age of 61 years. She'd had initial neoadjuvant chemotherapy and debulking surgery, and as part of her MDT setting, they were looking to pursue molecular profiling, including HRD testing. Somatic HRD testing of a biopsy was requested, and with the request, if you like, to see whether she was eligible for maintenance therapy with a PARP inhibitor post chemotherapy and internal debulking surgery. So the rationale, effectively, in this case, was HRD testing for a patient with high-grade serous ovarian cancer. Next slide, please. So in this case, we were looking for laboratories to report an HR deficient or HRD positive case with positive genomic instability score, and we were expecting laboratories not to identify any BRCA1 or BRCA2 variants. So overall, the genotyping for this case was done very, very well. There were no critical genotyping errors reported in the context, but I'm going to give a caveat here. So although the HRD status itself was concordant with the validated results for this case, in 81% of the laboratory reports assessed, should I say, there were 7 laboratories using the Illumina TSO 500 assay that reported this sample to be negative, HRD negative, with a negative genomic instability score. Now, we have had an ongoing discussion with Illumina about the reasons for this problem. And after lots of investigation, we've established that the reason for it is that the sample itself was too perfect. So essentially, the Illumina assay looks for a percentage of tumour cells, and of course, as this was an artificial sample, the sample was too perfect, in effect, to be 100% tumour. So the Illumina assay failed on the if you like, the check associated with the amount of tumour present in the sample. So due to that problem, we decided not to award any critical errors to to any laboratories in case one that reported it to be HRD negative. Next slide, please. A further 19% of laboratories failed to state the cutoff values for the genomic instability scores for their assays in the report, and they will have received a deduction as a consequence of that. And 7% of laboratories reported a test failure where the genomic instability score could not be determined. Next slide, please. Looking at the interpretation, again, 100% of laboratories got the correct interpretation, but that's caveated. So 78% of those received full marks. And we did apply deductions where laboratories have failed to provide either full clinical interpretation of the reports or provide patient-specific recommendations as a consequence of that interpretation. So just to really reiterate, if you like, that clinical interpretation should be tailored to the specific reason for referral or the patient tested and the specific results obtained. So again, I think this probably reflects just test setting and quite often the use of templates, for example, to provide a result that's rather than actually something specifically tailored to the question that's being asked about that patient. Next slide, please. So on to case 2, again, a female patient, 61 years of age, diagnosed with high-grade serous ovarian cancer. She'd had a cytological evaluation after a mass had been found. The consultant had ordered somatic HRD testing to determine or guide clinical decision-making concerning maintenance PARP inhibitor therapy. So again, the rationale, similar to the first one, HRD testing requested for a patient with high-grade serous ovarian carcinoma to determine eligibility for maintenance therapy with PARP inhibitors. Next slide, please. So in this case, we were looking for laboratories to report an HR proficient, an HRD negative sample with negative genomic instability score, and there were no pathogenic BRCA1 or BRCA2 variants found in the sample. There were a small number of laboratories, just under 4%, that got a critical genotyping error. Remember, critical genotyping error in the context of EQA is something that could potentially cause patient harm. Looking at the incorrect results reported, 2 laboratories reported a positive genomic instability score, whilst another laboratory reported an intermediate genomic instability score, so something that was borderline negative with intermediate, should I say, HRD status. 25% of laboratories failed to state the cutoff points for the genomic instability score, and 6% of laboratories reported a test failure where their genomic instability score could not be determined. So again, those latter 2 points are very similar to the first case, and I think we'd expect to see that obviously in the third case as well. Next slide, please. Interpretation, again, done very, very well. So 100% of laboratories got the correct interpretation, and 74% of those received full marks for interpretation. Next slide, please. Finally, on to case 3, a lady, 64-year-old lady, newly diagnosed patient with high-grade epithelial ovarian carcinoma, and she'd had an ultrasound and CT scan had revealed moderate ascites and a mental thickening. She'd received platinum-based chemotherapy, which the tumour had responded to, and her consultant has requested HRD testing of the biopsy sample to guide eligibility for maintenance treatment with PARP inhibitor therapy. So in this case, the rationale was a patient with high-grade serous ovarian cancer who had responded to platinum-based chemotherapy, and HRD testing was being requested to determine eligibility for PARP inhibitors. Next slide, please. So this was a much more challenging case. So we were looking for laboratories to identify HR deficient or HRD positive sample with a BRCA2 variant, a frameshift variant present at about 35.5% variant allele frequency. We expected laboratories to find that the GIS score was negative. Just under 18% of laboratories reported a critical genotyping error here, so a significant error rate, consistent with what we'd expect to see with a challenging sample in newly implemented tests. When we look into detail about the reasons for error, 8 laboratories failed to report the BRCA2 variant. and we'll talk a bit more about that later on. But six of those laboratories were using the same test, so there's a commonality there. Although this time it wasn't the Illumina test we talked about in case one. And a further 7 laboratories failed to provide the correct HRD status, although they had reported the correct BRCA2 variant. 2 laboratories also reported a test failure where no results could be determined. Next slide, please. Looking at the interpretation, whilst there were a lot of errors in the genotyping, if the labs did get the genotyping correct, then there were 100% of the results the interpretations were correct, and a further 61% of those laboratories received full marks for this EQA case. Some laboratories stated that BRCA testing is not performed concurrently with HRD testing as part of either their local policy or their regional practice, and in those cases we were careful not to assess the clinical interpretation as a consequence. Again, deductions in case 2 were very similar to those in case 3. However, there was a caveat here because obviously the presence of a BRCA2 variant does mean that there is a potential germline cause of that BRCA2 variant. And so we applied deductions where laboratories specifically not recommended germline testing or as a minimum referral to clinical genetics for ongoing assessment and downstream testing as a consequence of it. So again, the key point here is obviously the BRCA2 variant. We need to establish whether there is a germline cause of that variation. Next slide, please. So looking at the methodology, so Nicola showed the number of different tests that have been evaluated through some of the clinical studies prior to the, if you like, the implementation clinically in the real world. In this EQA, as we said before, that we're agnostic of the approach laboratory use, so we encourage laboratories to use any HRD applicable test, whether that be LDT or a commercial assay. There were 19 different assays used in this EQA. Nearly 99% of those were NGS-based assays. Next slide, please. Next slide, please. Yes, 99% of those were NGS-based assays, and one laboratory used a CNV array, a Thermo Fisher OncoScan CNV assay array. So again, NGS is the predominant technology, as I think we would probably expect to see in this context. But again, there's a massive variation in the different assays people are using, and this table shows the significant variation within the context of the methodology used. Next slide, please. So looking at the scores, so just to recap on the way that EMQN scores their results, laboratories get 2 marks if they get everything correct, and for every mistake they make, they lose marks from that score of 2. If you get it completely wrong, you score 0. So when we're looking at the mean scores for each of the different cases and the categories within the case, green being the genotyping, purple being interpretation, and the grey being the clerical accuracy and reporting style and format, we would expect to see the laboratories, very few laboratories will score, the mean score will never really be 2, but it should be close to 2. And that really indicates that the standard is high, and that, generally there's nothing too much to worry about. But as you can see here, the cases 1, 2, and 3, case 3 was the challenging case, and the mean score for genotyping was considerably lower than the mean score for cases 1 and 2. Again, reflection of the fact that that was a challenging case. Next slide, please. Then we start to dig into the performance trends. Obviously, this is only the second year that we've run this EQA, but we're already starting to be able to look at we can now start to look at some of the data. So of the nearly 100 laboratories that participated, about 90 or just under 90% of them submitted results for assessment, which is great. Of those 10% of laboratories that didn't, the majority of the laboratories withdrew from the EQA scheme up front, with a very small number not submitting results or informing EMQN of why they weren't submitting. So essentially a high submission rate, which is good to see. Looking at the scores, again, we've just gone through the assessment scores, but close to 2 is what we'd like to see. So a score of about 1.8 to 2 is I think certainly acceptable within the context of this first run of the EQA. Looking at the critical error rates, A high critical error rate, overall mean critical error rate, which is to be expected given the fact that 17% of laboratories made a critical error in case 3. So the overall critical error rate for the scheme itself was about 7%. So going back to that, those published data, that up to 25% of error rate in new emerging tests, 7% whilst high is not so high that we will be alarmed by the level of error being established. And reflective, I think, of a test that actually is performing pretty well in the context of how new it is into the clinical practice. As this is a first year we're running it, there was no poor performance for laboratories. So although laboratories made critical errors and would have had feedback from EMQN accordingly, we didn't classify any laboratories as poor performers in this year. Next slide, please. Finally, just looking into the details of performance trends. There were in case 2, so case 1 we're not including for the reasons we discussed previously. For case 2, there were no common trends, if you like, between why laboratories didn't made an error. But in case 3, you can see there are some trends with respect to technology used. Specifically for case 3, there were 6 laboratories using the Oncology Comprehensive Assay Plus that failed to report the BRCA2 variant, but reported the samples HRD negative. So again, like the findings we had for case 1, we have investigated that with Thermo Fisher, and the reasons for the assay failure was not actually a failure of the assay itself per se, but because the bioinformatics thresholds were high. So there were a couple of laboratories that used that kit that actually did identify the BRCA variant. So the reason for those 6 laboratories failing was because their in-house validation wasn't sufficiently robust and needed to be improved to align with the thresholds of the bioinformatics from the Oncomine Assay Plus itself. So I guess a key learning, if you like, for those laboratories to make sure they do more validation around the implementation of that test. But what is good to see that it's not a systematic problem with the assay itself. And really, it just highlights the need for improved validation or verification, should I say, when you're implementing a commercial assay into clinical practice. Next slide, please. So some key learnings, which I think sort of really echo the learnings that Nicola shared earlier on, perhaps more specific to the actual test implementation process. But when reporting a continuous score, the assessors recommended that the laboratories state the validated threshold for clinical actionability. So a problem we saw in the first run in 2024, and we see again this year, that many laboratories still fail to include the predetermined assay-specific cutoff values for the genomic instability score. So although we didn't deduct for it, we made recommendations for laboratories to improve that reporting component and ensure that they provide the predetermined cutoff point in the report somewhere, so it's clear to see what it is and how they've actually measured it. Some laboratories failed to state the final qualitative HRD status, so proficient, positive or deficient, or negative and proficient. And unlike clinical samples, the variants we identified in the EQA scheme shouldn't be submitted to public databases. So obviously, as an organisation, we've got a large number of laboratories participating in the EQA, and there is a potential to skew publicly available data within those databases if laboratories enter our results, or the EQA results, into those databases. So just if you like, a plea from laboratories, please don't use this data for submission to public databases. Overall, though, the EQA materials perform very well, with next to no test failures reported across the different EQAs, across the different cases, should I say. Next slide, please. Interpretation. So 97% of clinical reports link the genotyping result to PARP inhibitor therapy. Important aspect of the clinical interpretation. And obviously there are potential variations with local policy here, but it's really important to make sure that link is established in the clinical report, and therefore preventing mistreatment opportunities due to inadequate reporting. Multiple different assays were used, with 19 different assays were used. It's also, but we're still, it's too early to do much about it at the moment, but we're definitely still seeing a need to standardize the reporting results. And obviously we're working on guidelines to help support that. But the EQA is showing quite significant variability with how laboratories are reporting the results. And there's definitely a need for improved standardization of that. Laboratories themselves are using a range of different terminologies, including HR proficient and HR deficient, HRD positive and negative. And in some instances, the GI score itself was described as the HRD score. So again, some learning around how you actually report and use the terminology associated with this type of test. And we touched upon this in case 2, and that's really the importance of ensuring that if you do find a BRCA1 or BRCA2 or even an HRR gene variant, that you do recommend confirmatory germline testing and counselling provided in the report, or at least referral to genetic counselling as a consequence of it. Next slide, please. Some other observations really from the EQA as well this year. There's still significant interest in HRD testing. We didn't have sufficient, we had more laboratories registering expression of interest than we had available places on the EQA scheme. So just if you like a reminder for next year, please do get your EQA registration in early to ensure you get on the EQA. We've seen I think a pretty good snapshot of the HRD testing practices reporting, but there's more to do, and we need more data on that to really help drive improvements in standards, along with the best practice guidelines which are coming. But overall, I'm encouraged to see there was a high level of inter-laboratory reproducibility of the test process. The error rate of 7%, whilst high, is not overly high compared to the introduction of other tests, and given the fact this is a very complex test, it's encouraging to see. Many laboratories do not indicate the genomic instability score cutoff values. We talked about that, and a validated threshold for clinical actionability is absolutely recommended. And again, the reporting language around HRD status is variable, and improvement could be made there, as we described in the interpretation section. So my next and last slide, I think, please. So a reminder of the key dates for 2026. The registration process has closed. The samples themselves will be shipped in September, middle of September, I think, with an 8-week turnaround time for results submission. And we aim to republish those results before the end of April 2027. Obviously, we have in the middle of that the assessment process, the Christmas holiday period and New Year. So we will try to turn those around quicker if possible, but certainly no later than April 2027. Okay, I think that's the end of my presentation and the summary of the EQA scheme results. Nicola, I think it's over to me and you to do some questions and some Q&A. I haven't looked yet, but have we got any questions?
Sure. I think that one of the questions that came is about the result with Illumina, and whether Illumina is going to change their workflow following these results. I'm not sure this is going to happen, Simon, because I think that this is a artificial sample, so I'm not sure that Illumina is going to change the workflow based on these results. What is your feeling?
Yeah, I agree with you entirely. I mean, it's that dilemma that as an EQA provider we have about how do we provide a sample that works in all different assays. And particularly when you're sending the same sample out to 100+ laboratories, it's just not practical to do that on a real tissue sample. So obviously real tissue is the ideal scenario, but it's just not possible within the context of running a global EQA scheme for HRD testing. So we are kind of constrained by the reference materials we use. And it's true that I don't think it's not an easy one to get around, because there aren't many HRD reference materials available commercially. And if they are, they're quite expensive to buy, and there's an impact both for us as the provider, but also for the laboratories as well, if they want to use them as reference materials. So we're kind of constrained to providing samples that are close to perfect, but not perfect, if you like. So we will never be able to get around it. I just cannot see. I mean, it's not realistic or even fair, I would say, to expect Illumina to change their assay just based on the EQA samples used. I think the key thing for us is that we have showed in the other cases that this assay worked well on the other samples. So this was a specific issue related to this one case. And that the assay itself wasn't failing. It was nothing to do. It wasn't a problem with the assay from Illumina. It was really a problem with the sample itself. So I don't think it's to come back to your original point. I don't think Illumina would change their assay, and I wouldn't expect them to change their assay as a consequence of that.
There are some more questions. You want to open also the question?
Yeah, I'm going to put this one to you, I think, Nicola. So there's a question about if you had to implement a new HRD test with a commercial solution, what would be your first or maybe your top 3 choice? Now, it's a difficult one for you, but you can't recommend any specific assays. But
of course.
Obviously, but you've given some pointers in your presentation. What would you say?
Yeah, I would say that, I mean, that depends on a number of variables, starting also from the platform that you have available, because for some labs, the choice is also related only to the platform. However, there are a number now of published validation, clinical and analytical validation of this assay. Please don't refer to studies in which the validation was performed on 10 samples, 20 samples. I mean, this is not sufficient to validate a so complex biomarker as HRD. So, but there is plenty of these assays have been validated on mostly the Paula, but also other samples from other clinical trials. So I will go look into this. And for the validated samples, for those that have a very good analytical and clinical validation, there is not much difference. I mean, you will never have 100% concordance. You don't have concordance for HRD. You don't have concordance for BRCA. And I mean, we had these I mean unexpected cases that were discordant for BRCA in our study, and you have seen also the results presented by Simon, which were quite surprising. There were more errors for BRCA rather than HRD testing, which still keeps the issue of how this BRCA is covered by the different panels. So I would really look into this, and of course this depends also on how confident is a lab with the different technologies. So this is also an issue that must be taken into account. So choose this assay that are validated, do an internal validation, which is fundamental, and participate to EQA. This will allow you to give the best that you can do for your patients.
Yeah, I think that's totally fair, Nicola. I think coming to your point about BRCA testing itself, I mean, yes, intrinsically you would expect that the BRCA testing should be the easy part of the test process, because there's so much more complexities in some of the other parts of the test. But we already know from our EQAs itself that BRCA testing is much more complex than people assume it is. In case 3, where large, nearly 18% of laboratories got the result wrong, 6 of those laboratories were using one methodology we talked about, the Thermo Fisher technology, where it wasn't an assay-specific problem. It was a problem of bioinformatics associated with it and lack of verification of the commercial assay in the lab test. So coming back to your point, I think that we can't overemphasize enough that whichever assay you do, good validation of that assay is absolutely critical to good implementation in the lab.
So, but Simon, for those 6 cases, so the BRCA variant was sequenced. I mean, was covered by.
Yeah. So when you go back to the detail, obviously we dug into the detail from the laboratories. The variant was detected, but the thresholds was set high in the assay itself, and the lab's additional validation on its own clinical samples hadn't picked up that high threshold and the impact of that on the variant calling. So the assay itself is picking up the variant, but the bioinformatics associated with it is missing it. Again, it's all parts of the assay, of course.
That's also what we found. But you are pretty bad in having a BRCA variant in a sample that was with the low genomic stability score, because usually, I mean, not always, but usually, the BRCA mutants are also a very high genomic stability score that can help you to go back to the sequencing data and revise the data, as I suggested. But maybe next time we have to. This was really a challenging sample, so I have to say, Simon.
Yeah, absolutely. But then the EQA is a combination of routine and more challenging educational cases, if you like. And it's not. It's whilst it's not common. It's not. It's not. You still find it in real life, and so it's important to include variety of different contexts and samples associated with it.
Um, There is a question about the use of HRD in other tumor types other than ovarian cancer. Of course, I think that this is interesting. There's a lot of research on this, but I guess that these assays, the one we have discussing today, and be validated in ovarian cancer, and we should make sure that they have the similar also in results also in other tumor types. For example, for maxillary instability, not all tests work as well in all the different tumor types. So I think that these steps needs to be done before you really use your assay to call HRD in other tumor types. Simon, do you have any experience on this?
No, I have to say I've not had any experience in doing of implementing HRD in other tumor types, Nicola.
So there are also, I guess we covered also another question regarding the classification of the variants. The issue is that if the variance is filtered out by the bioinformatics, you will not see the variants, and so you will not be able to classify. That's the issue. That's why the recommendation is that if you have an high HRD score, look at your data. If there are variants that have been filtered out, you might look into that, and if
Yeah.
they might be really BRCA variants. So unfortunately, the issue is that you don't see these variants usually from this pipeline because they are filtered out.
That's very true. But again, it emphasizes why the EQA is really, really important, because EQA is fantastically good at identifying systemic problems in the test approach. So in isolation, those laboratories wouldn't have known they had a problem. But the EQA can highlight that because everybody's testing the same sample and people are using the same assays associated with it. So it's possible through the EQA process to challenge your laboratory and understand or try to identify systemic problems that you can't see in routine validation or clinical practice. We have another question just come in, Nicola. Do you know which threshold value was too high in the OCA plus assay? So that's case 3. I'm afraid I don't know offhand, but I think it is actually written in the report. But if the person putting the question wants to ask me directly, please go to office@emqn.org, and we'll look out. We'll try to understand and let you know what the cause of that was.
Yeah, actually, I was quite interested by the fact that there are some labs that are reporting the genomic instability score of the HRD marker, but not for BRCA. Usually, it happens just the other way around. At least in Italy and in some centers, they do test BRCA and then they test for HRD only in the BRCA wild type. How is this possible? Because this is going to create really a very difficult algorithm to handle also for the patients. I mean, there are many labs doing this that you know from your observation.
I don't know offhand how many labs are doing it, but it's certainly, I think, something we could look at in more detail in the next round of EQA. Try to understand a little more about the trends of laboratory practice and how that's actually impacting the results. I mean, there's also a case here, Nicola, a question here about the use of MDTs and the importance of having the MDT involved in the assessment of the clinical data. Do you have any?
I think.
Go on.
Yeah, go ahead.
No, I'm just curious to see your perspective on that, because obviously the use of an MDT is not consistent across different centres, and it's something obviously we're looking at in terms of developing quality assurance through IQN path. But what's your experience with the way MDTs are being implemented, and particularly with respect to decision making associated with a test prescription?
Yeah, the question is really referred to the cases that are we find some in which you find the
Mm,
BRCA variant is BRCA positive, but the HRD score is not high. I mean, this is possible, and of course, a molecular multidisciplinary team would be very important for the discussion for all those cases in which there is you have a value of the score close to the cutoff, as I said, or your cases like the case 3. In my country, in Italy, at least within the regional oncology networks, the multidisciplinary team works pretty well. And I found very interesting the discussion that we have on specific cases. We don't not discuss all the cases, but these cases are discussed. And I think this is any kind of interaction is very important. But I have to say also that most of this multidisciplinary team, at least in Italy, are not supported by specific funding. So it's a really
mm,
more like volunteer uh,
yeah.
basis, and but they are really fundamental for, I mean, to address this specific issue, in particular when there are, let's say, results that are not really clear cut, and sometimes you have values that are or results that not really correlated to the pathogenesis of the disease or something that is an unexpected finding. I mean, this would be very important to discuss. And actually, I've seen also that there are some labs that are reporting intermediate value of HRD. This is also quite strange because at least when you look at the commercial assays, you have a threshold and a cutoff, yes or not. So this
Yeah, yeah.
intermediate value that comes from an internal validation, I don't know. What do you think?
I would like, well, I'd hope to see it comes from internal validation, but I don't know, I can't be sure. And I think that's part of the problem. I mean, even within context of the MDT thing, we don't know. All we're assessing is what the laboratory's written down, and we have no idea. Um, yeah, and we certainly won't get it from their report about the detail of their validation and how they've done it, or whether the outcomes of the test have been discussed within an MDT. All we see is obviously the clinical report and the outcomes from that. So it's hard to really draw an objective decision about what the process is that laboratories have gone through. But maybe it is something we should look at, try and dig into a bit more detail in future rounds of the EQA, actually understanding the pathway associated with the test itself. There are a couple of other questions, Nicole, that are coming in really
Yeah,
aimed at
why?
you, I think. Um,
Okay.
uh,
So the first on the percentage of patients that have genomic
yes.
stability but not BRCA alteration. Well, looking, I mean, we know that BRCA variants have been identified in approximately 20% of ovarian cancer patients, including both somatic and germline. So the data that are available and are published in several series suggest that at least another 20 to 25% of patients have genomic stability, even in absence of a clear BRCA alteration. So the phenomenon is there, and there are different data published. But if you want, you can drop me an email, and I will send you some reference. There is also another question.
Yeah, and the concept of HRD reversal. So is HRD reversal genuine? We see a very small number of cases with where BRCA is positive, but HRD is negative. We attribute most of this to tumor purity issue, but occasionally tumor purity high cases have shown to be HRD negative.
So I think that, I mean, let me make it in this way. We use this test as tests for HRD, but we are not sure that these are the best tests that and are really capturing all the biological phenomena that occur in tumors that have BRCA variants or generally have some deficiency of the homologous recombination. And for example, we found also that some of the assays that showed the lowest correlation with the reference essay at the end that the best correlation with the outcome of the patient. So I think there is a lot of research and still needs to be done. It is possible, I mean, also in our experience, very rare to have a BRCA positive with HRD negative, and these are cases that actually should be discussed. I think that here, the multidisciplinary team will be very important. And the first issue
Mm.
is that in these patients, you have the response to first-line chemotherapy that is platinum-based. If a patient has a very good response to platinum-based chemotherapy, I would bet that the patient is HR deficient or if HRD positive, as you want to define, independent from BRCA, HRD signature, and so on. So we have really this also clinical biomarker that we can use to classify this patient, and we should couple with this. So it would be interesting to know if this BRCA positive with HRD negative signature are responding or not, and what type of response do they have to platinum-based chemotherapy, because this will help us to better classify these patients. Then there are some cases that are BRCA mutant and they also carry BRCA reversion mutation. Some are acquired. In other cases, the BRCA reversion mutation has been identified also from the beginning. I'm not sure whether this is going to influence, the development of an HRD signature, but these are few cases, and I think we need to have more research on this before we can provide an answer.
Okay, thank you, Nicola. I don't think we have any more questions coming in. So in the absence of any more questions, shall we wrap up?
It's all on you, Simon.
Let's wrap up then, if that's the case. So it just leaves me to thank you, the participants, for dialing in. We really appreciate you dialing in and giving us your time so we can share our experiences of HRD testing. So thank you for dialing in. Thank you also to MSD AstraZeneca for supporting this initiative. Obviously, without their support, it makes a huge difference to us, their support, and certainly organising this webinar. It's greatly appreciated. And thank you finally to my co-host and co-chair, Dr. Normano. Nicola, thank you for your time and your insights as well, your clinical insights. It's always great to have you involved. And we look forward to sharing this webinar with your colleagues once we publish it in a couple of weeks' time. Do keep an eye out from that notification out from the EMQN. And we look forward to you joining us in the 2026 EQA scheme. So with that, thank you very much indeed and have a good afternoon.
Thank you and good afternoon to everyone.